Okay, so again, welcome here in Sicily, and my presentation will be about depression. You heard about bipolar disorder. This will be about depression. Uh, let's start with the problem, why we are here and why we talk about depression. Which are the needs of advances in the treatment of depression? Well, of course, a simple depression is very easy to treat. We know all it. If patient presents in our hospital with depression, usually you give a first-line SSRI, and it's very simple. Problem is that it's not working for many of the patients. And there are then a lot of options. In this presentation, we will discuss the various possibilities that we have now and the advances that have been done in the recent years and in the future that are available for treating depression in a difficult situation. But first, the concept that from an anatomical point of view, we need to treat depression. I remember that in the past years, there were some psychiatrists that were suggesting that depression should not be treated because it's normal in human beings. My opinion and also the scientific evidence is that depression should be treated. Particularly severe depression is a disease that should be treated. If not treated, it gives anatomical changes, in this case to the hippocampus, but not only. And if you don't treat depression for a long time, more than 2 or 3 years, the damage in the brain might be irreversible. So it's very important to have the goal of making the patient stay without depression. Also, this I say very clearly because I see many times that there are situations where a patient with depression is treated with some antidepressant with partial response or no response, and then it goes on for years this way. No, we have always to struggle to try to have a complete response. And in this presentation, we will discuss the steps that are needed to obtain this complete response in all patients. Of course, it's not easy, but in my 30 years experience, I can say that it's very difficult that a patient has no response if you follow the right steps. Maybe it can take 6 months, 8 months, but at the end you receive some benefit. But there is a big heterogeneity. Some patients respond very quickly to treatment, as I said before, and these present no problems. You give escitalopram or sertraline or whatever, and then you have response. But then there are patients that are much more complicated. Some patients have initial worsening, some patients don't respond at all, some patients respond and then don't respond again. So we have to do something. This is the main topic of my research in the last 30 years. The point of finding the right treatment for every patient. Of course, depression is a very wide concept. Patients can be depressed for very different. So some people demonstrated that 10,000 different combination of symptoms can lead to diagnosis of depression. So we have a lot of different depressions. And of course, there is also the environmental influence on depression, like the pandemic story now, economic problem, wars, and so on. So, of course, it's very complex to talk about depression. But being complex, we have also a lot of tools. We have, of course, psychotherapy that is not part of my presentation. You heard it before. But we have more than 100 drugs, and we must know how to use them because they can be of big help for the patients in an individualized way. So let's talk briefly about some of the options that we have and the new concepts that we have, the advances that we have for each of these new options. I know that also tomorrow Professor Dilbas will talk about augmentation and switching, and so it's a very important concept to discuss a little bit in detail. But when we have problems in antidepressant response, the first thing to do is optimize the dose. This seems simple and trivial, but I tell you that I've seen so many times that patients are treated with doses that are not adequate. Uh, to make it clear, if you treat a patient with 50 milligrams of sertraline and you see nothing, there is no point in going on another 2 months with 50 milligrams. Go to 100, 150, 200. This because more or less the antidepressants used at right dose, they are more or less similarly effective. So there are no big differences between one compound and another in terms of overall efficacy, provided that they are used in the right way in terms of dosage and time. But they are different in terms of tolerability, and they are different in terms of individual response, because some patients may not respond to sertraline, but may respond to venlafaxine and so on. We focused with a series of papers, here I put only a couple of them, on the importance of dosing. We have demonstrated that for escitalopram, duloxetine, venlafaxine, and also mirtazapine, and now we have also new data, that the dose is extremely important when you treat patients. The example that I told you of low-dose sertraline, it applies also for escitalopram or for all the other antidepressants. If the plasma level is too low, like in this area, for example, or this area, you have no efficacy of the treatment because it doesn't block the serotonin transporter and the other mechanism of action depending on the compound. So under treating a patient is a clear way to obtain no response. Same way, if you give too high doses, there are not many data, of course, but too high plasma level gives too many side effects. And so patients are uncomfortable and stop medication. So it's important to stay in the exact plasma range of the treatment. If you have the possibility to do the plasma level of the drug, it would be perfect. But if not, try to use it from a clinical perspective. So go high until you see some side effects. So the right plasma level is a key important point to treat patients in an appropriate way. And this is for escitalopram, duloxetine, and many other compounds. So couple of slides that we just saw just to focus on the main point of dosing. The right dose is important. Okay, and this is simple. Let's go to the more complicated part. What to do when the treatment doesn't work very well and which are the advances in this field. Switching. You will hear this also tomorrow from a different perspective, but switching I think is an important point. When I started my career more than 30 years ago, I remember that switching was normal. Everybody told me, well, if a patient doesn't respond to an antidepressant, you change the antidepressant. Normal. Nobody questioned that. It was in all the guidelines, it was normal strategy. But after many years, this point has been challenged a little bit. Are we sure that when a compound is not working, we have always to switch or not? Let's focus on some point. This was a paper that we did a few years ago with the European team, and that demonstrated a very important point that when you switch, in case of non-response, of course, across class, that means from SSRI to SNRI or to tricyclics, or you switch within class, well, if you change a class, you have less benefit. And this was a little bit surprising because usually in the past, what we always thought is that you have to switch class because if serotonin reuptake inhibitors don't work, you go to tricyclics or noradrenaline reuptake inhibitors. But this is not the case from experimental data. If you change SSRI to SSRI, probably is more effective. But this was even more interesting that not switching across class or within class, but continuing the same antidepressant versus changing antidepressant. This was a subsequent paper that was based on the initial finding, with the thinking, but if we change in the same class is better than change class, what if you continue with the same antidepressant? Well, it was surprising to see that if you continue with the same antidepressant, you have a very good rate of response. So 4 weeks and another 4 weeks, 8 weeks. And this is counterintuitive because usually things, well, if it doesn't work, then we have to change. It's not so simple. In fact, we have seen that when you don't switch, you have a higher rate of response compared than when you switch. And interestingly, the time course is very, very important because when you switch, you don't have any change after the switch for 1 week, and then, of course, you have an improvement. You see that those two lines of improvement are almost parallel. It means that when you switch, you lose 1 week because you need the time for the new compound to work. Because you know the antidepressants are not like aspirin or antibiotics, they're not immediate. There is a cascade of events from block of serotonin transporter, new early genes to be created in the brain, plasticity of the synapses. So it takes 1, 2 weeks to work. So when you change, you lose time, basically. And this was a new concept that was not present in the past. And this idea of not clear benefit of switching was accepted in the last more recent guidelines based on this and other papers, challenging the old view that switching is always the best thing to do. And we did it also for escitalopram vaccine. I will not take too much time on that. So, the summary of switching. Summary of switching is not always okay. So 30 years ago, we were thinking that switching was the perfect strategy. Today, we think no. Today, we think that switching may be okay only if there is no improvement at all. So if the patient shows no signs of benefit, less than 20% on the scales, Madras or Hamilton, then probably it's a good idea to switch. But if the patient has an improvement of 20, 30, 40%, there is some improvement, probably switching is not the best idea. Probably we should use other strategies that we will see later. And I jump to this because it's connected. Which specific drug to switch? Also, the idea of changing classes has been challenged, and it has been deleted by many guidelines indeed. Now we think that changing classes is not so important. It's important to change compound if you want, but not to change classes, because the different pharmacodynamics they are so different also within the same class that different classes have no meaning now. In fact, there is this new nomenclature that probably you heard that has been suggested by CNP that the old classes and terms are probably to be changed in the future. The new Kaplan textbook of psychiatry will use this new nomenclature of treatment. Another reason for switching is that if there is poor tolerability, of course, if the drug is not tolerated, then it's good to switch. The strategy of switching, well, usually in the style, it suggests that for some compounds you have to do a cross-tapering, reducing and increasing. That is very simple, that if the pharmacodynamic profile is very similar, you can change also in one day. If the pharmacodynamic profile of the two compounds is different, then you need 1 week of cross-tapering. Okay, and the other points we will discuss later. So we have seen that switching is not the only possibility. Switching could be useful only in some cases. Then which are the other possibilities? Combination. Combination is not a very common strategy. Combination means two antidepressants together. And it has been suggested, I remember more than 20 years ago, Some people also tried with a trial, the famous COMED study, to see if you start with two antidepressants at the beginning, if two is better than one, if patients have a bigger benefit. It doesn't seem so. So starting with two antidepressants at the beginning is not a good idea, also because you have tolerability issue with no clear benefit of possible antidepressant effect. So when to use combining? Combining has been studied very recently by this very large meta-analysis, and the results, as you can see, are not very clear. It doesn't seem that combining two antidepressants is so effective. Why? Well, it is quite clear if you think about it, because when you combine two antidepressants, you have a very complex pharmacodynamic effect in terms of receptors that you don't know exactly what is happening. And then you have the interaction between these two compounds. Interaction in the liver in terms of metabolizing possible increase of plasma levels. You have possible risk of serotonin syndrome if you use two SSRI or SSRI and SNRI. So it's quite complex to combine two antidepressants. I like the conclusion of this meta-analysis that suggests, okay, you can do combination only if you think about it. Think about it in terms of use two antidepressants that have a very different mechanism of action. For example, use SSRI and trazodone, SSRI and mirtazapine that have a different mechanism of action. So patient is going better with escitalopram, but not sleeping well, then we can put some trazodone, we can put some mirtazapine. Probably this is the only clinical suggestion, because to combine two pure SSRI like sertraline and fluoxetine, it doesn't make much sense. And of course, you have to check on the databases about the possible interactions in the treatment that you're prescribing. So summarizing this part, combination of two antidepressants is so powerful is not so clear. Much attention should be pointed to the interactions and to the pharmacodynamic interaction. There is no clear evidence which specific drug should be combined, probably the ones with different mechanism of action. Okay, we have seen switching, we have seen combination. Let's see about augmentation. That is probably the most common strategy when treating depression, and let's see which are the advances in this field. Let's start from the Bible. I teach to my students to study on the Maudsley guidelines because, in my opinion, are the most useful that are available here for clinicians. And this is the last edition of 2021. Augmentation is the concept of adding something that can augment, that can improve the antidepressant response that we are observing. So this is connected to the slide of a few minutes ago. I told you that switching should be done when there is no improvement at all. But if you prescribe an SSRI and you see some improvement, then, and the improvement is not complete, it's a partial improvement, then you can do the augmentation. So the improvement on the first 1 or 2 weeks is the key point in deciding what to do. No improvement at all, okay for switching. Some improvement, augmentation. Augmentation with what? And let's answer to this question in the next few slides. You may do augmentation with a wide range of compounds. It's important to choose the right one, depending on the symptomatology, the preference of the patients, and so on. The first choice, according to the Maudsley guidelines, is to use aripiprazole. We will discuss aripiprazole a little bit in detail in the next few slides. There is A good evidence for using it is supported by data. It may lead some akathisia at doses higher than 10 milligrams. And we will discuss the dose issue later. The Mosley guidelines also suggest to add lithium. Well, lithium augmentation has been suggested many years ago. Probably lithium augmentation is most effective in combination with tricyclics than with SSRI, even though the studies are not so many. But lithium could be a good option, for example, as you have heard in the previous presentation, in bipolar depression with mixed features, then could be a good option. And then there is the combination of olanzapine and fluoxetine. Why this combination? You have heard this morning about the other combination of olanzapine that has been approved by FDA just last year. But olanzapine and fluoxetine was approved even earlier. Olanzapine is indeed very useful as augmenting treatment for depression, and fluoxetine is a synergic effect. But let's talk about, for example, when olanzapine or when aripiprazole. I would say that they are not the opposite, but almost the opposite. You can use olanzapine as augmentation when your initial treatment with SSRI gives a partial benefit with some residual insomnia, anxiety, or agitation, and then olanzapine is a good strategy. But remember that olanzapine can lead to the usual, we will see tomorrow morning, the discussion on antipsychotics, but can lead to weight gain, can lead to the other things. So it's not good for every patient. Aripiprazole, on the opposite, is the partial dopamine D2 agonist. That means that gives a 30% of stimulation of dopamine D2, so it stabilizes dopamine D2. So it's not that sedative, of course. On the opposite, it can be stimulating. So depending on the profile of the patient, one or the other. And then the Mosley guideline also suggests the use of quetiapine. Quetiapine, you know it very well. I think is the drug that is more with a wider range of use in psychiatry. You can use it 25, 50 milligrams as antihistaminergic, sleep-inducing treatment. You can go to 150, 300 as antidepressant. You can go to 600, 800 with antipsychotic efficacy, even if not that strong, but there is some. Then there is bupropion, dopaminergic stimulation, good for some patients with decreased energy and so on. And then some combination. Let's focus on the atypical antipsychotics. This is quite an old meta-analysis that was suggesting that almost all of them is very small, so maybe you cannot read from there, but it is olanzapine combination with antidepressant treatment. Olanzapine is mainly effective, risperidone mainly effective, quetiapine mainly effective, aripiprazole mainly effective. So initial evidence suggested that almost all second-generation antipsychotics could be used as augmentation for partial response induced by antidepressant. However, remember that at least in Europe, not all of them are approved, only quetiapine. The other are approved at different levels by FDA in the United States. I focused on aripiprazole since many years indeed. This is more than about 15 years ago review that we did on aripiprazole. And aripiprazole, the data that we had at that time was indeed more effective both in response and remission compared to placebo in the treatment of depression and anxiety in combination in various ways. This is a review of the evidence that we had so far. And this was 15 years ago. And what now? This is the most recent meta-analysis, this is last year or this year, that made a very nice comparison, the typical network meta-analysis that are very famous now, because they have limitations. Let's not go into detail. I have another video in my channel discussing about meta-analysis, but they have limitations, but they are useful. And in this network meta-analysis, they compare the efficacy and tolerability of the second generation antipsychotics that we just discussed when used in augmentation for antidepressant treatment. So this paper just answered to the question that we are discussing now. Which second generation antipsychotics should be used as augmentation when patients shows a partial response? One limitation of this approach is that this is a general approach. So it's not divided patient by patient. I much care about individualization. So some patients may have more insomnia, some patients may have more somnolence. We don't know. But let's start from the general pooled efficacy numbers, and then we can go into detail from symptomatology. This is quite interesting because let's look, for example, at this last line. All the second generation, aripiprazole, olanzapine, quetiapine, brexpiprazole, cariprazine, ziprasidone, risperidone, all of them are better than placebo. So the first answer that we have from this very large pooled analysis is that indeed all second generation combined with antidepressants are better than placebo in case of incomplete response. Interesting. Let's see if there are strong differences across them. Well, we see that the higher number is for risperidone, but the ziprasidone is not much used, followed by aripiprazole, followed by quetiapine, followed by brexpiprazole, olanzapine, and cariprazine the last. Makes sense, because if you think about literature, cariprazine is the one that is probably more effective in bipolar depression or in negative symptoms in schizophrenia, not much in major depression. And the other are more or less as expected. This is for efficacy. And what about tolerability? Let's look at, for example, this is the dropout rate for tolerability issue. And always compared to placebo, we see that indeed the one that was the most effective, that was risperidone, is also the less tolerated. Because risperidone, well, I'm not using much risperidone as augmentation treatment in depression because, in my opinion, it's too much antidopaminergic. Risperidone is perfect in many cases of schizophrenia, but for depression, I don't know why the numbers are so high, because my personal experience is that it's not that risperidone is that effective as antidepressant. But for sure, I agree with this number, 0.91, that risperidone is not very well tolerated. So let's be careful. Which is the best tolerated? The best tolerated is cariprazine, but was also the least effective in the other slide. So we have to combine all the information. Aripiprazole, better tolerated than risperidone, but with some issue. Olanzapine, a little bit less tolerated, and the others, as you see. Always talking about aripiprazole, another important question, and I liked a lot this analysis because this is very clinically oriented, because many papers usually do not think in terms of clinicians. This one, yes. Another question is how much aripiprazole we should prescribe. And this is a common issue that guidelines are not very clear about that. This is also for Quetiapine, but for quetiapine it is more clear because you know which is the curve of pharmacodynamic effect of quetiapine. For aripiprazole, it was less clear, but I like this meta-analysis that evaluated the impact of the different dosages of aripiprazole. At least my experience is quite common. Many times I have residents that ask me, well, professor, the patient is not responding to the antidepressant. I thought about aripiprazole. How much should I prescribe? Well, how much, of course, depends on the clinical situation, but as usual, we should start with the lowest dose. Antipsychotics, including aripiprazole, we have seen can lead to some side effects like akathisia. So I would say let's start with low doses, 5 milligrams, for example. But the question is, 5 milligrams of aripiprazole are less effective than 10, are less effective than 20? This meta-analysis is very interesting because it gives a very clear answer. The answer is no. Aripiprazole is effective in treating depression, refractory depression, at 5 milligrams, with no further improvement with higher doses. This makes sense. In my experience, there is no point in giving 20 milligrams of aripiprazole to depressed patients. Why? And think about the slides we have seen before. Above 10, 15 milligrams, you can have some side effects, neurological side effects like akathisia. So it's much better to use 5 milligrams in combination with the antidepressant so that you have efficacy and you don't have tolerability problems. There are no reasons to go to 20. Some patients, maybe you can go to 10, but 20 or 30, it seems that there is really no reason. Another interesting review is this one of a couple of years ago that focuses on another point related to the combination of aripiprazole and antidepressants. What happens in the long term? How long we should go on? 1 month, 2 months, 6 months, 1 year. Interestingly, in this paper, they see that there are, of course, not many studies, but in the studies that are there, is that there are no particularly relevant issues also after 1 year, 52 weeks. So it is possible to go on for quite a long time, but they suggest to use low doses, 5 milligrams or even less than 5 milligrams. And the tolerability is good with those doses. So the suggestion is, if you have an improvement with the combination, augmentation, sorry for the word, augmentation of aripiprazole antidepressant, we can go on for a while, 6, 8, 12 months. And if the patient is well, then we can, as usual, try to decrease. With the European group, we did another kind of study where we try to understand after, this is not a prospective study, this is a retrospective study, where we try to understand why clinicians like us prescribe aripiprazole or prescribe quetiapine to resistant depression. And it was very interesting to see that the choice of clinicians is to prefer aripiprazole when patients have a more psychotic depression. That makes sense because we know that aripiprazole is more dopamine modulating than quetiapine, particularly at low doses. So this study gives another piece of information. Aripiprazole, good as augmentation with antidepressants, it may be considered, particularly in those patients that have some psychotic features, some psychotic symptoms, even mild or with not complete response. Then we did another study with the colleagues in North Italy. That was very interesting because we were worried that if you have kidney renal failure, the plasma level can increase too much. And then we had this follow-up study of what is more than 1 year about the plasma level of aripiprazole. This is long-term treatment, depot treatment. And indeed, we saw that the treatment, the plasma level during more than 1 year in patients with hemodialysis, so it was a severe kidney failure, it stays within the range. So there are no worries about to use also long-acting aripiprazole in patients with kidney failure, provided that, of course, they do hemodialysis as suggested by their doctors. This was another interesting point. Okay, let's go on with the other strategies. We have seen all the strategies that are called first choice. Now we look at the ones that are second choice, when the first choice fails or when the first choice is not effective. We have a few possibilities. One is ketamine. Ketamine and esketamine. Well, you probably are familiar with ketamine and esketamine. It's quite famous at present after about 20 years from the early Carlos Zarate paper in 2005. Intravenous ketamine is clearly effective. Intranasal ketamine, some suggest that it is probably less effective than intravenous, but is more practical, of course. Not all patients respond to ketamine or esketamine, so it's not a miracle drug as we thought 10 years ago, but it's a useful drug and it is a place particularly for rapid treatment. Lamotrigine is probably a very good option mainly for bipolar patients, but also for unipolar patients. It stabilizes the patient at a higher level in terms of mood compared to the previous treatment. Of course, electroconvulsive therapy is the final stage. In my experience, electroconvulsive therapy is always effective, but of course it has all the disadvantages of electroconvulsive therapy. Thyroid hormone, well, there was much enthusiasm in the past, now a little bit less, unless the thyroid is not working, of course. And then there are a lot of other possible strategies that we will not go through all of them because they are of marginal interest, even though some of them can be useful for a specific patient, you can see on the Mosley guideline. So let's go to the end of this presentation and let's summarize what you've seen so far. When augmentation is to be used? Well, if there is an improvement that is more than 20-30%, when there is a partial improvement. So first-line treatment, some improvement, but not complete improvement, then is a good time for augmentation. It must be individualized on the basis of many features, the symptomatology profile, the comorbidity, medical comorbidities, the preference of the patient, the past efficacy, the usual criteria. And of course, there are the usual disadvantages of polytherapy. This is obvious. You must control for interactions and so on. Which other possibilities we have? We discuss ECT, but we have also the transcranic magnetic stimulation that is not so new, but it depends. Some years is more on fashionable, some years less, but there is much discussion on it because someone suggested to change the frequency, they suggested to change the positioning of the magnets. Well, it is a possibility. Of course, you need the equipment that is quite expensive. You need the skill that is not easy to do it, to perform it. The usual light therapy, the old vagus nerve stimulation, that is electrical stimulation of the vagal nerve, very expensive, not much used indeed. And the deep brain stimulation that is used for OCD, that is electric stimulation through the head in some specific areas. The problem is that in obsessive compulsive disorder, they know which are the area, or at least some. In depression, still is not clear which area we should stimulate. And then we have all the new pharmacological strategies that I will discuss in detail in the meeting of next month. If you will be there, I will make a whole presentation about the new treatment and the new strategies. Ketamine we already mentioned. We have psilocybin. Psilocybin is very interesting because you need to prescribe it only once. You give psilocybin one day, and then it's effective for 1 month, probably also 2 months, 3 months. That is a wonderful thing, of course. There are many studies on it, both on depression and on obsessive compulsive disorder. Still not yet approved. Ketamine is approved, psilocybin not yet. And then there are all the new neurosteroids that have been recently approved by FDA. They are very interesting because they are well tolerated. They are useful for postpartum depression, but also for other kind of depression. So they are emerging treatments that are very interesting, and I will discuss this in my next presentation. So to summarize, I liked a lot of this paper published last year in JAMA Psychiatry by the Italian Maurizio Fava and Roy Perlis. Maurizio Fava now is director of Harvard. And they suggest that depression now should be treated in a different way compared to the famous STAR*D study that was done more than 20 years ago. We have to make use of all the possibilities that the world offers, like mobile applications, all the smartwatches that we have that monitor all the parameters, very useful for us to see if patients are responding or not. We have to use different strategies. I like this sentence that I underlined. There is evidence now of the futility of continuing to switch. Wonderful. So 30 years ago, I started my presentation telling you 30 years ago, everybody was telling that switch is the main strategy for patients that don't respond. And now everybody agrees that is not that case. Switch is only for some patients, but not for all of them. And then we have to use all these new drugs to understand how they work. As ketamine, this new bupropion plus dextromethorphan, we will discuss this also, the neurosteroids, and the augmentation strategy, which is the best, quetiapine, aripiprazole that we discussed, or the brexpiprazole that is coming. So these are the questions for the psychiatry of the next 10 years that should be analyzed in the next studies. So I think I'm almost in time. Conclusions of my presentation. Well, first point, very clear that depression should be treated until remission. We should not stop in treating. We start, we see what happens, and then we choose in an algorithm until we achieve as much as possible complete remission. We reach this target using various strategies. There is not only one. Depending what happens, there is some kind of algorithm of decision. Combination is potentially useful. Switching, not so much depending on the situation. Augmenting is very useful, but is quite complex because you have to choose exactly which augmentation and with what. The final word is personalization. Every patient is different. So, of course, a patient should benefit from switch. Some should benefit from antidepressant plus aripiprazole or other with antidepressant plus quetiapine, depends on the patient. Okay, thank you for your attention.